diarrhea, and also prevention from diseases that were being carried by people. They believed that some people were could carry some diseases that could not be treated in hospital, and these herbal medicines offered prevention from these diseases, and that they would offer treatment for these common childhood diseases and also for the same diseases that were caused by people who were carrying these diseases. They also believed that these medicines were superior compared to the conventional medicines because they could treat difficult illnesses. According to the people of Silibwet, is that when a child was taken to a hospital and would not respond and would not be given a diagnosis, they believed that that disease was difficult, and therefore it's only herbal medicines that could treat them, and the same for chronic illnesses. And they also believed that generally children who used these medicines were stronger compared to the ones who did not use them, and they would grow in muscle bulk, their immunity would be strong, and they would achieve their milestones faster compared to the other children. On the next slide, it just shows some of the examples. One mother said that it is a must. You know, when you go to the market, people are many and you will meet their shadows. You may not know who has bad eyes. If you don't wash with the Kipsigis medicine, they will cry continuously and carry those spirits. That was from a mother. And then another mother said that doctors don't know. They will just tell you that the disease will go away. The herbalist will give you herbs and the disease will go away in a few days. Next slide. So the other theme that came up was that these drugs were safe, in that the sub-themes were they were safe in terms of they did not have any major side effects. And the only side effects that were mentioned was a rash when these children were given these medicines, and they actually believed that the rash was a sign of the disease going away. So they did not consider it actually a side effect. It's just something that they noted after giving their children. And the other sub-theme was that they got these medicines from trusted sources. They said that medicines for children could not be sold in the market, and they would just pick them from their farms of their own farms or farms of people that they trusted. So next slide. Some of the example was that I have never seen any child with any side effects. They just become strong. Sometimes you can see a rash, but that means that the disease is leaving the body. That was a female community healthcare worker. And then another mother said, no, children's medicines cannot be sold in the market. Children are very sensitive. You only get it from people you know and from your own family. So that way it will not harm the baby. Next slide. So some other emerging themes were medical pluralism, whereby the caregivers were combining both herbal medicines and conventional medicines, especially the ones used to bathe the children, because they said you have to bathe the children daily until they're about 2 years of age. And they did not think that they would interact with the other conventional medicines. Only 2 participants out of the 14 that were interviewed said that they could not combine the two. And in that, they meant the oral ones, but all of them washed their babies. And then the other theme was about disclosure to healthcare workers. Only 3 participants said that they could disclose the use of herbal medicines to the doctors when they went to hospital, and their main reason was that doctors, their attitude towards herbal medicine was bad and that they would scold them. And the other theme that emerged is that they use these medicines to conserve their culture. Next slide. So one mother said that bathing my baby with herbal medicine is a must. Hospital medicine does not affect that. I will only not give them oral ones because they may be too strong, unless I give one in the morning and another one at lunchtime. Another one said, the doctor, I cannot tell the doctor because they normally tell us in hospital not to use these medicines. They make a lot of noise for you. I will keep my own secrets. Next slide. So the findings of this study on the fact that these caregivers in Silibwet used these medicines to protect their children from evil eyes and shadows was similar to the findings of a study done by Ngere et al. In Kisumu, which showed that they gave their children herbal medicines to protect them from evil eyes. And the findings of this study also showed that the participants believed these medicines were safe and pure. And this was similar to a study done in Nigeria by Nwao and Oyelade, which said that mothers gave concoctions for malaria and convulsions to their babies because they considered them safe and pure. And in Saudi Arabia, 53% of diabetic patients disclosed the use of herbs to their doctors. And this differed from my study, whereby most of the participants preferred not to disclose the use of their herbal medicines to their doctors because they would be scolded. And in conclusion, caregivers believe that herbal medicines are protective, safe, effective, sacred, and offer treatments where conventional medicines could not. The biggest reason for use of herbal medicines in all the participants was protection from the evil eyes and shadows. And given that over 95% of the caregivers were using herbal medicines, education on safety of these medications should be provided. Herbal practitioners should be sought by the Ministry of Health to help facilitate the research for this medication, and registration of these practitioners should be pursued. And this last one was actually a recommendation from the community healthcare workers that conservation measures should be implemented to ensure that these herbs are not contaminated so that they can be conserved because they are good medicines. Thank you, and I'm sorry for all the technical hitches.
Excellent piece of work there by Dr. Frida Faith. Let us appreciate her better. Thank you. And hope we are jotting down our questions, because after the fourth presenter, we shall be taking questions. Thank you. So our next presenter is David Mogaka. Mogaka is our Year 5 Bachelor of Pharmacy student. She's awaiting graduation. Is a research enthusiast with keen interest in infectious diseases. Even currently, as he awaits graduation, he is doing a short course on infection prevention, courtesy of WHO. Mogaka worked on a methanolic extract of Aloe secundiflora, testing its antifungal activity against Candida albicans, and even coming up with a mouthwash formulation of it. And today he is joining us online to present to us the findings. So help me in welcoming David Mogaka. Thank you. Karibu Mogaka.
Okay, good morning.
Morning.
I hope you can hear me.
Yes, yes, we can hear you.
Okay, thank you very much. I'm David Mogaka, and I'm very glad to present today. And I hope you can see my slides there. Okay, thank you. This is our research we did for the graduation and for the final paper for our graduation as pharmacists. So we were evaluating Aloe secundiflora extract using methanol, and then we tested it against Candida albicans, then formulated a mouthwash. So, and these are my other authors we did with. So the next slide, please. Okay, much of my work was done with Frederick Oluoch yesterday, and so whatever he said yesterday about us coming up with a new alternative medicines or complementary medicines to aid in cover up for the diseases we have. And in my key interest for infectious diseases, this research came as a good hand for us. And so we did this research, knowing that there's an increase in infection diseases, mostly the communicable diseases, as WHO noted in 2018, with fungal infection mostly being on the rise. Also the fungal infections like Candida. So we have more than 150 million people dying, all with infections worldwide every year of fungal origin. And Candida albicans being one of them, caused by Candida, the species causing candidiasis. Mostly it's prominent in people who are immunocompromised. And those, we all know, those of us who have been to the department of the critical care where we have the HIV immunocompromised patients, they normally have these opportunistic infections and Candida being one of them. So the next slide. So in solving this problem, aloe, we used aloe. And as we all know, aloe is one of the plants that is been most studied, and most researchers have done a lot of it, phytochemical study and a lot of study on it. And most people are normally known with aloe vera as the most common known species. And now we have another species. Normally we have more than 500 species of aloe, and one we tackled with was aloe secundiflora, which has had a lot of studies done, but most of the studies have not covered it on the fungal Candida albicans. And so aloe's antifungal activity has been shown well, and we were going to work on it to formulate a mouthwash. Next slide, please. And so to the problem statement, one of the problems we have in the world right now, and as Dr. Frederick said it yesterday, it's microbial resistance. And as you all know, we have had a lot of discoveries of antifungals. We have many antifungals which have provided a good care to our problems of fungal infections in the world. But there is this major issue of resistance rising, which is causing a lot of problems to critical care. And as WHO could say, there might be a problem in the coming years if we don't solve the problem of resistance, as most infections could not be cured. So we coming up with another alternative treatment, we thought it's good to solve this resistance issue. So another problem is that is leading to a high rate of infections like Candida is inadequate sanitation and hygienic events. It's hard to say that Kenya is one of the third world countries and growing countries. And as the president could say, we are tackling a lot of slums to upgrade slums or some, unhygienic places. We have like, also, let me not call them unhygienic. We have a lot of growth areas growing up, and inadequate sanitation is one of our problems to kill. And this has been attributed by many studies to causing fungal infections. And the other one is cost. As one of the keynote speakers yesterday could say, we have a lot of rising cost of infections, and we need to look for a way of reducing the cost, because not everyone could afford fluconazole or clotrimazole to get the treatment. So the next slide. So our main objective was to determine the antifungal activity of the aloe secundiflora extract, and then test it against Candida albicans, and then finally formulate the mouthwash. Next slide. So we had specifics. So first of all, we were to extract a mucilage from the aloe secundiflora. Then we were to evaluate the antifungal activity of the extract and then formulate a mouthwash. And finally, we had to find out whether the mouthwash had activity against Candida albicans after the formulation. The next slide. So this is our conceptual framework for what we used to help us get the discussion and get us to determine the factors affecting our independent and dependent variables. Next slide. So our research design was a laboratory-based experimental design. So where first we had to acquire the samples. We had 2 samples to acquire, the Candida albicans, which we acquired from Cambridge through the aid of the pharmacology and pharmaceutics lab, and we had to acquire it. And then we had aloe secundiflora, which we had to acquire from around Campiamoto. So we had to get access to it through some people who have planted it. We had to verify the samples when they came to the lab through our technicians we have. They had to verify whether we have, as you all know, we have many species of aloe. So we had to verify that it is aloe secundiflora and not aloe vela or other species. Then we had to go to extract our mucilage where we used methanol, and we extracted our mucilage in the lab. The next slide. So after extraction, we did preliminary phytochemical screening. And as you all know, every plant has some phytochemicals that are essential in determining whether there's an antifungal activity or some activity of the given plant. So we tested for some phytochemicals, we tested for carbohydrates, we tested for tannins, we tested for flavonoids, anthraquinones, saponins. And then this could help us to determine whether which one was responsible for the antifungal activity that will be shown. And then we went further to perform antifungal activity test where we did disc diffusion of our extract against the Candida albicans. We also had to do serial dilution to get the different concentrations, which we used to do minimum inhibitory concentration, which could help us to determine what concentration to use in concentration of the mouth. Yes, and then we had to formulate the mouthwash, and these were the ingredients we used to formulate the mouthwash. We had water, alcohol, sodium benzoate, glycerol, and we used honey as one of the sweeteners. Although it has some other activity, we used it as a sweetener to help us emulate the activity. Next slide. And so these were the zones of inhibition. After finding out the disc diffusion, we had to find out the different concentrations and their impact they had on forming the different activity against Candida albicans. And so we did for the different concentrations where the highest concentration was 333.33, having the highest zone of inhibition of 8.27 millimeters, and the lowest one of 4.11, having the concentration of 5.82. So we did use our positive control, fluconazole, and then our negative control. And then after formulation, we came to find out our mouthwash had a zone of inhibition of 7.6. So from these results, I used them to discuss. So as we all see, the highest concentrations at the highest zone of inhibition. And we used the concentrations to formulate the mouthwash. The next slide. So from the minimal inhibitory concentration, where we had to determine which formulate another, we choose which concentration could help us to formulate the mouthwash. So we test the clearance component of the BDT, and we determine the other intensity that could be used to, sorry for that. So we had to determine which concentration could be used. And as we could see, the 111.11 milligram per ml was the one that showed a little bit clearance of the candida. And then the 333.33 showed the highest. The other concentration showed negative clearance of the candida. So the two concentrations with positive clearance were the ones that could help us to formulate. Next slide. So when we tested for the phytochemicals, these were the results. The saponins were absent. We didn't get the saponins. For the tannins, they were present, but in minute concentrations. Then we had test for flavonoids, where we tested using different tests. These different tests for flavonoids can help us determine a specific flavonoid that was responsible for the activity. So we had to do all the tests to see if a specific flavonoid was responsible for activity. As we can see, the ammonia test showed a little presence of flavonoids. The Shinoda test showed negative, and the others, like alkaline and the later acetate, showed a high concentration of flavonoids. For anthraquinones, at first they were negative, and the modified one, which is used to test even the minute concentrations, showed a little bit. As we all know, aloe is made up of some flash liquid, so we had to eliminate the liquid, and the liquid is mostly made of anthraquinones. And so as of our study, we didn't expect to have anthraquinones. So yes, okay, that's right. And then, so next slide, I think I discussed. Yeah, so as I was saying, the flavonoids were the ones that showed the highest concentrations, and they were the ones present in our mucilage that we extracted. And we attributed them more to causing the antifungal activity that was observed. Because as of Nguyen et al. At 2021, their research, they could say flavonoids are the ones that act mostly like other fungals by causing the inhibition of the cell membrane. And so they are implicated to causing antifungal activity. Also, other studies have shown that tannins and carbohydrates that were also present have shown to have antifungal activity by inhibiting their growth factors. So our study of having flavonoids and tannins is helpful. We can attribute them to flavonoids, tannins, and carbohydrates. But as I said, flavonoids, we have different types of flavonoids, and the studies we shown also if we can go to the previous slide, we had different alkaloid flavonoid tests that we did, and we find out that flavonols in the alkaline tests could be present. The next slide. So the flavonols are the ones that have been attributed mostly to causing the antifungal activity, and are maybe the ones responsible for our activity, because as the alkaline test, they were the ones present. And so with our study, we conclude that the antifungal activity was present using the methanolic extract, and the tannins, flavonoids, carbohydrates were the ones present, showing the inhibition of activity. The next slide. So we recommended some further studies to occur to isolate the specific active components. As I've said, we have these flavonoids present in the aloe extract. So we need to find out the specific, so someone can extract the specific flavonoid, or even do some studies and evaluate the specific formulas of flavonoids that could be helpful. Also, one can do mouthwash optimization through enhancing the formulation. As you heard Frederick said yesterday, we have had some problems with quantification of our studies on herbal extracts, where you need a lot of samples and a lot of kind of the liquids you use to extract, where you need a lot of it so that you can get the required extract, the required concentration. So we need to work on optimization. We need to look for a way of optimizing the concentration to get. So also, for us, we fashioned ourselves into a mouthwash, but also one could make up, because Candida albicans is not only acting as on the mouth, as we say, oropharyngeal candidiasis. We also have vaginal candidiasis. So one can venture into formation of a pessary that can be essential in curing the vaginal candidiasis caused by Candida albicans through the formulation of the aloe secundiflora mouthwash. Next, and I think we are done. Yeah, these are our references, and thank you very much. And if you can go to the first slide, you can see the picture of the mouthwash we formulated. Thank you very much. Yeah, that is the mouthwash we formulated. Thank you very much.
It deserves some better appreciation, isn't it? Thank you, David, for that good work. Let's continue also writing down the questions so that afterwards we can front the questions to them in the Q&A section. The next presenter for the day is Dr. Sarah Vugigi. Dr. Sarah Vugigi is a senior pharmacist who has majored in pharmaceutics. In fact, she holds a PhD in pharmaceutics, and currently she's a lecturer here at Kabarak University, again teaching pharmaceutics. She has got a vast experience in quality control, quality assurance, and pharmaceutical production and products. Our focus right now is on dosage forms and physical pharmacy practice. She has previously worked as company pharmacist in Ellis Pharmaceuticals Limited, and also a pharmaceutical analyst at DARU, that is Drug Analysis and Research Unit of the University of Nairobi. Dr. Sarah Vugigi formulated a shampoo from Ricinus communis leaf extract, and also evaluated its efficacy and efficaciousness. And she's here physically to share with us her findings. So ladies and gentlemen, help me bring to the stage Dr. Sarah Vugigi. Thank you.
Good morning. My presentation is on formulation and evaluation of Ricinus communis shampoo for tinea capitis. This work was done with Vicky Protich, who is my co-author. Under the introduction, I'll give us information on tinea capitis, on the resinous. Tinea capitis is a fungal infection of the scalp caused by dermatophyte species, Trichophane and Microsporum canis. The infection occurs mostly in pre-adolescent children in poor resource settings, and this infection is contagious. A study done in Mathare, Kenya, found a prevalence of about 81% for this infection. First-line therapy agent for tinea capitis is grisofulvin. Shampoos and ointments are used as adjuvants and also sometimes to curtail the infection. The problem of conventional antifungal products is that some of these products have significant treatment failure, especially with grisofulvin, which we have seen is the first line of treatment. We also have inherent toxicity, which is linked to the mechanism of action of these products. Also, in addition, we find that we have limited options and few discoveries are being done for these particular products. And this drawback has led to the pursuit of botanicals such as Ricinus cuminis, which are perceived to be safe, and they are also readily available. So I'll give us some information in regard to Ricinus cuminis. This plant is also referred to as castor oil, and it's a herb in the spurge family. It grows readily in warm climate areas such as Africa, Asia, and South America. And this plant contains flavonoids, saponins, alkaloids, and glycosides. And these compounds have been found to exhibit antioxidant, anti-inflammatory, and antimicrobial properties. Leaf extracts have demonstrated antifungal effects on Aspergillus niger. This is a study that was done by Carolina in 2019. So the objectives of our study were to formulate a shampoo containing Ricinus cuminis and leaf extract. The second was to evaluate the physical properties of antifungal activity of the formulated shampoo against tinea capitis. The formulated shampoo should have a distinctive appearance for identity, appropriate rheological properties, non-irritant, be able to form and exhibit antifungal properties. So this is what we call the target product profile. So this was the target specification, starting with the end in mind. So our purpose was to prepare a shampoo with the following specifications. The color would be green, with a pleasant fragrance, pH 5 to 7, because this is roughly the pH of the skin. This shampoo that we are designing should be non-irritant, should have pseudoplastic properties, so that when you rub it onto the skin, it can be able to spread easily. It should be rinsable with water, and of course, it should have antifungal properties. So this is the research method. This study was done at Kabarak University, School of Pharmacy. The Rhinus plant samples were obtained from Kabarak University Botanical Garden. The excipients that we used to prepare the shampoo, the microbial culture media, and the comparator product which was ketoconazole shampoo 2%, was sourced from local vendors. Mycosporum canis species, which was used, was obtained from Kemri, Nairobi. And this is how we prepared the shampoo. The plant sample was dried, ground, subjected to Soxhlet extraction. The extracts were then mixed with prescribed excipients in the prescribed quantities to form the shampoo. And we used Sabaro dextrose agar as our culture media. And this was tested for viability to make sure that it is able to support microbial growth. It was also tested for sterility to make sure that it does not contaminate the sample. This culture media was then prepared in accordance to the manufacturer's specifications. Evaluation of the shampoo. We evaluated the physical characteristics, and we looked at the color and clarity. This was done by visual evaluation. We looked at the ability of the shampoo to be able to produce foam. We checked the pH of the shampoo using a pH meter. We checked the flowability using a viscometer, and of course, we then looked at the antifungal properties. This we did by the diffusion technique. This was by the use of discs containing the test sample, and this was placed on the Sabaro agar containing the Mycosporum canis. The zones of inhibition were then determined. This was done in triplicate. We had 6 samples, 2 samples from the shampoo and 4 samples from the serial dilutions of the extract that we had obtained. These were our results. The appearance of the shampoo that we prepared was green. It was opaque, a pleasant smell, good forming properties, and it had a pH of 5.63. Then, in regard to rheological properties, this shampoo was pseudoplastic, meaning that as you increase the shear rate, there was the thinning of the shampoo that had been prepared. It was nicely viscous, 282 centipoise, and it could be able to foam. And these are the results for the mean zone inhibition. We had 6 samples. We did each of the samples in triplicate. The first sample that we had was the blank formulation. This is the shampoo matrix without the active ingredient. Then we had 100% Ricinus communis extract, 50%, and 25. We did this just to make sure that there is a relationship between the concentration of the Ricinus and the zones of inhibition. Then we had the sample containing the Ricinus extract, and this is the shampoo that we had prepared. And then lastly, we checked on the ketoconazole, 2%. This was our standard, just to see how it compared with the sample that we had prepared. So ketoconazole was the positive control, and the blank formulation was our negative control. And as you can see from the results, the blank had an average of 5.3 mm's, that's the zone of inhibition. And then we can see that as the concentration decreases, the zone of inhibition also decreased. So 100% we had a zone of inhibition of 10.01, whereas 25% we had 6.23 mm's. When you come to the sample from the shampoo that we had prepared, we see that the zone of inhibition was 11.01, 2% ketoconazole, the zone of inhibition was 11.21, pretty close. An interesting observation there is that in the blank, you can actually see that there is inhibition. In the blank, this is the matrix for the shampoo. And we did this because usually, sometimes the matrix that you have has inhibitory effects. And in this matrix, we had a forming agent, which is normally antimicrobial. We had preservatives, which are also antimicrobial. So that is why in the blank, we have some zone of inhibition. Then we did analysis of variance comparing the samples of ketoconazole, which was our positive control, and resinous communis, which is our sample. And you see that from the results, even before doing the statistics, the values are pretty close. The zone of inhibition for 2% ketoconazole is, the average is at 11.21, while the one for resinous communis shampoo, the value is 11.01. So the p-value for the two was 0.5996, which is more than 0.05. And so this shows that there is really no significant difference between the ketoconazole shampoo, which was our positive control, and the shampoo that we have prepared. This is our discussion. The formulated shampoo exhibits ideal physicochemical characteristics of an ideal shampoo. It had a pH of 5.63, which is ideal for the skin. When you apply it onto the skin, you will not get that irritation. It is also viscous, and this enhances its stability because it must have a specific shelf life, and it also helps it to have good flow properties. We have also seen that the pseudoplastic behavior that it has is a desirable property, since you want that decrease of viscosity when you rub this shampoo on the skin. So it has to become thin so that it is able to spread nicely as you apply it. The shampoo demonstrated remarkable antifungal activity that is comparable to 2% ketoconazole shampoo, which was our standard. And the inhibitory effects were due to the presence of steroids, saponins, alkaloids, flavonoids, and glycosides, and all these are found in resinous communis, according to a phytochemical analysis study that has been done. So this highlights the significance of an adjuvant therapeutic alternative for the treatment of tinea capitis. In conclusion, an antifungal shampoo containing resinous communis extract was formulated and evaluated. The shampoo demonstrated characteristics that are ideal for a shampoo in terms of physicochemical evaluation criteria, and also it possessed antifungal activity which was comparable to the marketed 2% ketoconazole shampoo in terms of the inhibitory effect on Microsporum canis. This shampoo is therefore a promising therapeutic alternative adjuvant to the conventional antifungal formulations. Recommendations. We need to validate these results so that we can be able to know that we can consistently get these results if done in various places. We also need to carry out stability studies so that we can be able to find out how long this product can be able to retain with it still attaining activity. We also recommend studies on the combination of the formulated Ricinus communis shampoo with conventional antifungal agents to determine synergisms and toxicity. Thank you very much.
Great work there by Dr. Sarah Bugigi. Let's appreciate her more. Thank you. Our next presenter is a final year School of Pharmacy student right here at Kabarak University who is awaiting graduation. Samuel Munene is also a skilled, certified public accountant, currently working as an accounts assistant at Plus Steel Enterprises here in Nakuru. And he is also aspiring to be an oncology pharmacist. Samuel Munene focused primarily on induction of insulin secretion, focusing on chemical analogs that are similar to phytochemicals that inhibit ATP-sensitive potassium channels. That is in the induction of insulin secretion, whereby he did virtual screening. And today I can see him here ready, so help me bring him to the stage. Thank you. Karibu.
Okay, thank you very much. So our project was on computational analysis of chemical analogs similar to phytochemicals that inhibit ATP-sensitive potassium channels. So my co-authors are Felix Otieno, Cynthia Chalo, and Dr. Richard Kagia. So on the background, diabetes mellitus is characterized by hyperglycemia, a chronic illness caused by either insulin secretion issues or insulin resistance. So the number of people with diabetes rose from 108 million in the year 1980 to 422 million in the year 2014. And this number is postulated to rise to 600 million cases by 2045. So this means that the prevalence of diabetes mellitus is on the rise, and it is rising more rapidly in the lower middle income countries than in the high income countries. So diabetes mellitus consists of two types, majorly, that is type 2 diabetes mellitus and type 1 diabetes mellitus. So type 2 accounts for 85% of the cases, and type 1 accounts for 10% of the reported cases. So the pancreatic cell ATP-sensitive potassium channels are critical for glucose metabolism because they govern insulin secretion. So an increase in ATP causes closure of the ATP-sensitive potassium channels, which leads to depolarization of the cell membrane and opening of voltage-gated calcium channels, and therefore influx of calcium ions to the beta cells, influx of calcium ions, which triggers insulin release from beta cells into the bloodstream. So currently, sulfonylureas are used to induce insulin production through the inhibition of pancreatic ATP-sensitive potassium channels. So with that therapy, currently there is no therapy that addresses insulinotropic activity of natural products. So, and from the past, natural products, that is from plant sources, have been used to control diabetes by the traditional medicine men. So these sulfonylureas, which include glipizide, glibenclamide, gliclazide, they target the ATP-sensitive potassium channels on the pancreatic cells. These drugs are associated with side effects, which include the weight gain, GI disturbances, and hypoglycemia. So several studies have shown some plants that have phytochemicals which inhibit pancreatic cell ATP-sensitive potassium channels. So these phytochemicals will include astragalin, lupulin, luciferin, quercetin, and resveratrol. So against this backdrop, this study is aimed at virtually screening analogs of phytochemicals that inhibit ATP-sensitive potassium channels on beta cells that induce insulin secretion with better pharmacological, pharmacokinetic, and toxicological profiles. So on the methodology, so an in silico study design was employed for this research using computational methods. So a literature search led us to the specific phytochemicals that were used in this research, which included astragalin, lupulin, luciferin, quercetin, and resveratrol, which were selected for the study. Glipizide, which is a molecule that is currently used for management of type 2 diabetes, was used as a comparator because it is an approved ATP-sensitive potassium channels inhibitor. So the structure and canonical smiles of these phytochemicals was obtained from PubChem website, and these canonical smiles were used to screen online databases via the online tool SwissSimilarity for structurally similar compounds. And the zinc database is where these structurally similar compounds were obtained from. So 20 chemical analogs for each phytochemical with the highest similarity index were isolated and used for further analysis. The structure of ATP-sensitive potassium channels with a PDB-ID of 5YW7 was obtained from the protein data bank and standardized using Chimera. This is the software that we used in the analysis. So Autodoc Vina was then used to dock the selected analogs for each phytochemical to standard ATP-sensitive potassium channels, and their corresponding docking strength was tabulated. Visualization of the complexes formed between the ligands and target protein and the interaction was carried out using BioVia's Discovery Studio. So SwissADME was then used to assess the pharmacokinetic profile and synthesizability of the selected 20 analogs for each phytochemical. And toxicological analysis was done using Protox server to determine the LD50 and the toxicological class. So on the result, these are the structures of the parent phytochemicals. And the first one is the structure of the glipizide, the comparator that was used. And on the table, we have the plant species from which the phytochemicals, the specific phytochemicals, were obtained from. On the next slide, we have the ATP-sensitive potassium channel. And on the box on top, we have, it shows glipizide inside the potassium channels binding pocket. So these potassium channels are large and cannot be visualized using the BioVia Discovery Studio. So on these tables, on the first table we have the parent phytochemicals. Then we have the number of analogs with binding activity greater than or better than the parent phytochemicals. Then the number of analogs with a binding activity that is better than that of glipizide on the ATP-sensitive potassium channels. Then on the other table, we have the number of analogs that were better in terms of the pharmacokinetic and toxicological properties. On the next slide, we have the ligand receptor interactions of these compounds with the receptor that is the ATP-sensitive potassium channels. So in this, we see that most of the bonds formed were the conventional hydrogen bonds. There was also pi-pi stacking and salt bridges that were formed. Then we have the pharmacokinetic, the next slide. On this slide, it shows the pharmacokinetic and toxicological properties of select analogs. These were the final analogs that were better in terms of the pharmacokinetic and toxicological properties. Then on the next slide, the previous one. So on this slide, we have the parent compounds tabulated in comparison with the analogs that had best results. Then on the discussion, so in docking analysis, the in silico binding analysis of select phytochemicals showed that quercetin had the strongest binding affinity for the receptor ATP-sensitive potassium channels with a docking score of negative 8.8. Astragalin followed at negative 8.5, then resveratrol at negative 8.3. Luciferin had a score of negative 7.8, while lupanin showed weakest receptor affinity. Glipizide had a docking score of negative 8.5, hence quercetin had a stronger affinity for the receptor than glipizide, which was the comparator. Astragalin had the highest number of analogs with better receptor binding activity than glipizide at 14 analogs, followed by quercetin at 13, with 13. This information is on the first table that I showed you. So the most prominent ligand receptor interaction was the conventional hydrogen bonding. So on the pharmacokinetic and toxicological studies, The issues that we checked most was the Limpinski rule of 5 obedience, the blood-brain barrier penetrability, GI absorption, CYP enzyme inhibition, and toxicological clocks. Only a struggling violated Limpinski rule of 5 and had a low GI absorption. A struggling and glupanin had no CYP enzyme inhibition activity. Lupanin was most toxic with 243 milligrams per kg, while astragalin was least toxic phytochemical at 5,000 milligrams per kg. Lupanin and its analogs exhibited favorable properties such as lipophilicity, GI absorption, blood-brain barrier penetration, absence of violations, and acceptable bioavailability scores. Nociferin and its analogs outperformed glipizide in terms of lipophilicity, gastrointestinal absorption, blood-brain barrier permeation, and had fewer enzyme interactions. In the case of quercetin, its analogs, they demonstrated reasonable lipophilicity, adherence to Lipinski rules, high GI absorption, and inhibition of certain CYP enzymes, while glipizide inhibits all tested enzymes except this cytochrome P450, 1A2, and 2C19. While glipizide may have some advantages over certain compounds, each group of analogs demonstrated unique properties that make them potentially more attractive for further research and development. So in conclusion, a total of 1,884 analogs based on the 5 phytochemicals was extracted from the zinc database. Out of this, 100 analogs with highest similarity scores were chosen for further analysis. The pharmacokinetic, pharmacodynamic, and toxicological prediction of 19 out of the 100 analogs that were chosen for further study showed better results, and hence there is potential for further studies and maybe in the future production. So these analogs listed were the best in the different compounds, that is astragalin, lupanin, nociferin, quercetin, and resveratrol. So that is the end of my presentation. Thank you.
A better round of applause to him once again. Thank you. So we quickly get into the Q&A section, and I hope we have our questions ready. So what we do is that you rise up and read through your questions. You say who you're directing your questions to. We have 4 presenters, that is Dr. Frida Faith, Dr. Sarah Vugigi, David Mugaka, and Samuel Munene. So simply you rise up and read through your questions. Then we will give our presenters a chance to just stand and respond to all the questions. So welcome. Thank you. So you can give him the microphone to start us off.
Okay. My question is directed to Dr. Frida. Thank you so much, Dr. Frida, for the good presentation on the caregivers and on the traditional medicine. Okay, in your conclusion, you stated that part of the recommendation is about safety. However, I'm also concerned about how herbal medicines sometimes deter patients from seeking a very critical conventional intervention. For example, I have this observation that when patients are diagnosed with, let's say, cancer, they tend to avoid going to the hospitals. So maybe I would like to hear your comment on, besides advising on the patients on safety, what do you think about this aspect of patients avoiding going to the hospitals because of maybe some beliefs that maybe if the patient if the patient is diagnosed with cancer, conventional medicines would cause more harm. So maybe that's the part that I would like to hear from you.
Oh, thank you. So thank you for the wonderful presenters. They were very good presentations. Also, my question goes to Dr. Frida. I'm just curious what your recommendation is with regard to the belief systems. What can we do as healthcare workers with regard to the beliefs that are already entrenched in the community? What can we do? Thank you.
Thank you very much for your presentations. I have one question to both David and Dr. Vugigi. Did you do any stability studies on your formulations? And if so, what were the results? And then to Samuel Munene, what are the next steps for the chemical analogs that you found?
Thank you. This is Dr. Gaja from School of Pharmacy. I had some questions for Dr. Frida. The first question I'd just like to know, did you get a sense of the type of formulations of plants that were used by the people you were interviewing to ward off what they were calling the evil eye? And secondly, were you able to get any indication of from whom they were actually sourcing the medicines? In other words, who was formulating or giving them the medicines that they were using? And then to Dr. Sarah Bugigi, I just wanted to know from the literature or any thing that you have been able to glean, has anyone else ever used or ricinus-based shampoos elsewhere that you are aware of? Thank you. All of them? Okay, from the first question to Frida, I just wanted to know if she got a sense of the type of formulation of plants that the interviewees used to ward off what they were calling the evil eye. And secondly, did they indicate from whom they actually sourced the preparations or medicines they were using on the children? You know, I think they said they were washing the babies or something, if I got her correct. Do you want the second one to repeat? Okay, for Dr. Sarah, I just wanted to know if there was anywhere else that this type of ricinus-based shampoos have been used to deal with fungal infections.
My question goes to Dr. Sarah Vugigi. You did an analysis of variance ANOVA for the, I tend to believe was the mean zones of inhibition. And based on the ANOVA results, you've, as indicated, the p-value was more than the requirement, 0.05, meaning there's no sufficient evidence to say that there is a statistical difference between the mean zones of inhibition of the shampoo you formulated and the conventional 2% ketoconazole. So this means in terms of usage, we can use the two because the difference in activity is not so much. So what might warrant us to rely more on the shampoo rather than on the conventional ketoconazole drug? Yeah. Thank you.
Thank you so much. To Dr. Frida, did you confirm, because one of your participants were the medical practitioners or the health providers, did you confirm any herbal medication that they thought that truly worked and should be incorporated into the health sector? Thank you.
Thank you. My question is directed to David Mogaka, the one who talked about Elois secundiflora. You presented the various zones of inhibition. You just gave us a list of this, the various sizes of the zones of inhibition, and I never saw you subjecting those various zones, their sizes, to the rigors of statistical tests. Just like you saw Dr. Ugigi doing an ANOVA to see if there is any statistical difference between the ketoconazole and the Resina Sambu. This one here, you never did any statistical test. So how do we tell that indeed the differences you pose in your results and in your conclusion are actually statistically significant without having not been subjected to the rigors of a statistical test? Thank you.
Thank you. So mine is an open question to the first presenter. In the context of the study, in relation to the evil eyes, what is your perception as an individual, and do you think per se it's curable by the traditional means? I'm asking this as a person of interest, because I've been affected by the same firsthand. Thank you.
One question. You had one question. The zones of inhibition that you gave us, you didn't subject them to statistical analysis. How do you think they are statistically significant, the information that you gave us? Please come and respond to that. Oh, he's online. David Mugaka, can you hear me?
Hello.
Yes, there's a question that has been fronted about the zones of inhibition that you gave. Didn't give statistical analysis about the data. So how can we tell that the data that you give is statistically significant? What would you say to that?
Okay, the data was subjected to ANOVA's analysis. It's only that it's not featured in the it's not featured in the slides, and I added it. If you go to the slides, there is that added section. It is added there. It's only maybe I forgot to mention because the slides were in slideshow mode. They are down there on the slides, and we did the study on analysis of the zones of inhibition, of the different zones of inhibition against the negative control and against the positive control. So on our analysis, we found out the p-value for the positive control being 0.1. So, and as we all know, if the p-value less than 0.05 is statistical significance, and ours was 0.1. It came to us to conclude that it was not that statistically significant, but seemingly it seems between the zones of inhibition that we used, maybe the active component was almost the same. Yeah, have I answered the question?
Thank you. Thank you, David. We can go to, so that we finish up with online, go to Dr. Faith Frida. Dr. Faith, if you can hear me, you have several questions lined up for you to read just at a few. There is a concern on how herbal medicine prevents patients from seeking conventional medication, even for very important, so to say, illnesses. You can comment about that. And also, what can you do to handle what can we do as health professionals to handle the issue of the belief system that is there about herbal medicine? And another one, did you confirm any herbal medications that truly worked that should be incorporated into conventional medical practice?
Can you hear me?
Yes.
Okay. So about the herbal medication affecting the timing for seeking care, that was actually one of the reasons, that and the toxicity that led me to go into the community, because you could sit in hospital and find that patients came in very late, and now they had the disease they had plus the effects from the toxicity of these herbal medicines. And it's true that people avoided conventional medicines for these chronic and big illnesses, in quotes. And it was mainly driven by their beliefs, because they believed that herbal medicines were superior. And I think this is where, as healthcare workers, we come in, because truly we do not know whether they are superior or not. We actually do not know what they contain, and we do not know how they should be used. And that is why what we can do in the meantime, as we wait for these herbs to be studied one by one, is to educate people on this, on their beliefs, so as to promote safety. So we just tell them they need to come to hospital, not because we are discrediting their medicines, but just because if you come with an overdose, I will not know what to do with you, because I do not know actually what you have ingested. Now, however, the big problem lies in the fact that also healthcare workers actually believe in the same. I was surprised when I went to do my study, because I found that also healthcare workers actually used these medicines and believed in the same. And so my thoughts going into this study were that I get what these people actually believed so that we can work on educational themes that we could do to the community. But now, after doing this study, I think the first people would need to start with are the healthcare workers themselves and do education to now, just targeting their we need a paradigm, like a paradigm shift. Because if we, the people who are to educate the people, actually believe in these things, then it becomes difficult. And on the recommendations to the community, especially to healthcare workers, I think we'll start now with those ones who believe that, yes, these medicines work, but we need to put them on hold until they're able to be studied so that we can be able to know how much to use, especially in children who are very sensitive to doses. Then there was a question on the types of plants that were being used. Yes, every participant was able to list the common herbs that they used, and some of them included the croton tree, the Prunus africanus, the Kebage capensis, the eucalyptus tree. There was a long list of medicines, but the interesting thing is that they would not all use the same medicines. It was dependent on the family, whatever your grandmother taught you, and they would mix these herbs. So they would pick roots of certain trees and leaves of others and put them all in a sufuria and boil and use it for their children. And they would even not share this information with other families because they considered it sacred, that we should just use it within this family unless someone has truly come to seek official permission. And even when visitors would come, they would cover these medicines because they believed that when other people looked at them, they would take away the power. And this one goes with the other question for where they sourced them. So they sourced them from their farms. They said for children, they were careful not to go to the markets because they did not trust vendors. And so for particularly this community, you would not find anyone selling herbal medicines for children specifically in the market. So for children, they would get them from the farms. And then for difficult illnesses where maybe their own medicines were not able to sort, then there were specific herbalists, two of which I have already interviewed one, but their findings are not yet in this study as this study is ongoing. So I will visit the two herbalists who were referred to me by the participants that I already interviewed. And so those ones were sought. They went looking for them when their medicines at home could not work. Then did you confirm any of these drugs, especially the ones which were being used by healthcare workers? So I didn't confirm that any of this worked because all of them used mixtures. They would just combine drugs. And if you ask them about the details of these drugs, they'll just tell you, I was just told by my mother or by my mother-in-law that this worked. And so I used them because I believed that. So there was no science or any dosing or any interests as such to be sure on the quantities or what exactly they contained. No one bothered to check, including healthcare workers. And then about the evil eye, my perception as an individual. Of the 14 participants that I am presenting their findings today, it's only one who used them for other reasons apart from the evil eye. And this one was, apart from being just a member of the community, was also a religious leader. She's the only one who didn't believe in the evil eye. And the reason why I think this belief is off or does not hold water is because even the medicines that they used to give them protection for this were different for different families. If it was a particular tree that they would all go for to give them protection from evil eyes, then maybe. And also, if I also asked a question to them that, have you seen a child who was not bathed with these medicines that got these illnesses from these people carrying these evil things and the evil shadows? And what they would answer is that, no, we have not seen, we just heard from our grandmothers and them, and so we are afraid not to do that because we do not want our children to contract those illnesses. So personally, I don't believe in that personally. Yeah. But we'll see. And it's surprising because this is a community that all these people go to church, they believe in God, and they say as much as God protects, we also need to cover our children because people are evil in the society. I hope I have been able to answer all the questions.
Thank you. Thank you, Dr. Faith Frida. She has answered all the questions, isn't it? Thank you. Thank you, Dr. So now from here, now that Samuel is here, so you can respond to that one question is, what next for these analogs that you analyzed virtually? What next for them? What should we expect? Samuel?
Okay, so what next for these analogs that I got that were better than, or better in terms of pharmacokinetic and toxicological and the pharmacodynamic aspects? So these analogs can move to the next step, which is in vivo and in vitro studies to ascertain that these claims are true. And after that, they can maybe start development for production. Yeah.
Thank you. So now the last but not least, Dr. Sarah Vugigi to respond to about 3 questions. Whether you did any stability studies on the shampoo, then if shampoos have been used before to deal with fungal infections, and is there any, did you find any sufficient evidence to show the difference in activity between the shampoo that you came up with and the drug test? Thank you, Dr. Karibu.
Okay, starting with the first one, in regard to stability, if you did look at my recommendations, I said that what we need to do is to validate the process, and then after that, we carry out stability. And this is because when you are developing a product, basically you have to do those preliminaries before you subject your results to stability. So what we hope to do is to validate the process from the harvesting to the extraction right up to the preparation of the shampoo. After we have validated that and we're getting consistent results, then we can subject this to stability. The second question from Dr. Gajo was in regard to whether this resinous cuminous shampoo is being used elsewhere. And my response to that is yes, we have shampoos being used as adjuvant. In fact, the ketoconazole that we used was actually a shampoo. So we have these products being used as adjuvants, and also they are used to prevent infection, because usually grisofulvin is taken orally. So you want something that you can be able to apply topically so that it can also be of adjuvant help. There was also a question on the justification. Why do it when there is no significant difference between ketoconazole and the shampoo that we're preparing? If you looked at our justification and problem, we did mention that the conventional products are inherently toxic. And so because of that, you want to get a product that you can be able to use, a product that is safe, and a product that is available. If you can be able to get a product that is safe and available, then you go for it. Actually, if you look at one of the side effects of ketoconazole shampoo is that you use it and your hair becomes red. You don't want that, do you? Okay. I think that was it.
Thank you so much, Dr. And thank you all the previous presenters for that in-depth feedback on the questions that were asked. My name is Meroka James, and I'm going to present to you the next presenter, who is Oronyi Isaac Osoro. Oronyi Isaac Osoro is a current 4.3 pharmacy student in the School of Pharmacy, Kabarak University. He has interests in the field of software engineering and likes doing coding. Today, he presents to us on the developing potential drugs for insomnia through computational analysis. Ladies and gentlemen, let us put our hands together as we welcome him to present on the online platform.
Supervisor. I am working on developing a potential drug for insomnia through computation analysis, which is almost 100% computer-based and using literature review. Yeah, my next slide. So insomnia can be basically described as lack of sleep. It is a condition that most of us have experienced in one way or another. The government of Kenya and most of the institutions have not laid out a nice strategy of dealing with this condition. It may involve difficulty in initiation or maintaining sleep. So it can be classified as into two, either chronic insomnia or acute insomnia. In chronic insomnia, we can say it is a condition where at least three months a patient experiences lack of sleep for 3 months consecutively, and at least 3 nights a week. That's when you can say a patient is experiencing a chronic insomnia. And acute insomnia is a condition where it comes once in a while. It's a condition where most of us usually experience, where the patient, maybe you change an environment, you go to a place where there's noise or more lighting than where you come from, so you tend to experience acute insomnia. So the prevalence in insomnia worldwide is about 10 to 30% of the world population. It is more prevalent in women than in men. It is recommended by the World Health Organization that adults should sleep at least 7 to 8 hours a day, and in children, it varies depending on the age, and the age from 5 to 10 years, the sleeping hours can vary. So in children, we can just generalize them. They should sleep between 12 to 17 hours. So in the problem statement, this is a condition that, as I said earlier, about all of us have experienced in one time or another. Mostly it is caused by factors such as stress, fatigue, anxiety, and sometimes environmental disturbances such as noise, excessive lighting, and other factors such as medication. We have drugs such as SSRIs, NSAIDs, beta blockers, which we know they cause this as a side effect of the drugs. The drugs such as SSRIs and beta blockers and NSAIDs are known to decrease the melatonin production in the body, while drugs such as SSRIs, example is the citalopram, are actually known for decreasing the sleep latency and actually continuity in sleep suppression in the REM sleep. And in some cases where the patient has been in some cases where patients are being treated with drugs such as patients with compulsive obsessive disorder will be treated with fluvoxamine, reported at least 31 to 37% insomnia cases. So it is also a risk factor in development of insomnia. Yeah, the next slide. The current medication therapy, no, the previous, the current medication therapy is applied in Kenya is based on the side effects of the available drugs. This exposes the patients to more drug interaction, and actually we are utilizing not the indication, actually the side effects of the drug. So it is also a risk factor. We don't get the desired therapeutic effect that we want. So the drugs that modify sleep pathway are not easily available, and if available, they are very expensive. As we are going to look in the next coming slides, we are going to see the drugs which have been availed by the World Health Organization and the European Research for Sleep about how expensive they are and how, as a common Kenyan or Kenyan citizen, a common citizen, you cannot be able to access those drugs easily. So why insomnia? So several conditions have been associated with lack of sleep. So such include hypertension, depression, Alzheimer's disease. There's a recent publication which was discussing about Alzheimer's and insomnia. It's a very serious condition that most of the people are going to much expenses dealing with them and knowing maybe their patients will not recover from it, or even if they will recover, it will take a lot of money to go back to the initial condition. But now, if we deal with this condition, it may decrease the risks of getting Alzheimer's. So also the immunological conditions, the lack of sleep is associated with conditions such as upper respiratory tract infections. There was a publication I'm referencing here. The previous year, there was on 2020-2021, there was a pandemic of COVID-19. Most people suffered from upper respiratory tract infection. So there's a linkage between insomnia and COVID-19, where it indicates that the patients who have low sleeping hours have a high prevalence of getting COVID-19. So this is due to decreased natural killer cell activity, decreased T cell and cytokine production, and reduced vaccine response. So this is a short video showing, you can play it. It's a short video courtesy of Lewis, I found. It's a video showing the clearance of, this is the activity of the cerebrospinal fluid. It actually works very effectively when somebody is asleep. It works to clear the brain of toxic material. The more accumulation of this toxic material may lead to brain damage and cause things like Alzheimer's, and also dementia. So, in the methodology, in computational analysis, the method, it is classified into three. We have three steps. First of all, we prepare the molecule, we prepare the ligand, and then finally we dock. Yeah. So we used Swiss similarity. We used PubChem to get the canonical smells of the molecules, molecular orientation. Then we used PubChem Sketcher to convert the canonical smiles into 2D formats of the molecules. And then we used Avogadro software to convert the 2D molecules we obtained from PubChem Sketcher to a 3D molecule. Then we use the same software to optimize. To obtain for the receptor, we can obtain the receptor directly from the protein data bank or the UniProt. It is the UniProt. It's an online tool, and then we next moved to cleaning the receptor. It is when the receptor is put there. Some people might have used it to do some other research. Now we need to clean it so that we can get a pure molecule. And then there is docking. We docked using the Chimera software. And then after then we used the Swiss ADME online tool to get the pharmacokinetic properties of the molecule. And then lastly, we used the ProtObserver to get the toxicity profile of the molecules. So I analyzed for molecules. The first one was Ramelton, Suvorexant, Triazolam, Zolpidem. These are the most commonly used drugs in insomnia. But as I have been in the hospital and attachment, I've not seen any of these drugs. The commonly used drug right now is TCA, amitriptyline. And it is mostly misused, and it is a TCA. It is commonly misused. So I use these drugs which have different mechanism of actions. The most promising molecule was most promising drug was Ramelton. Ramelton I've not seen it around. I went online and looked for the price. It's actually 621 shillings per tablet, but it is very active. It is very effective. Unlike melatonin, Ramelton has a long duration of action. So we will, for this presentation, we will focus on Ramelton. So these are the results. The docking score will use these results for the discussion. Ramelton had a docking score of 7.8. That was the basic factoring factor that we used to look for the other compounds. So the rest of the compounds we chose had better docking score compared to Ramelton. So you can see the rest are 8.5, 8.7, yeah, to the next one. Other factors included the LD50, GI absorption, brain permeability, P glycoprotein substrate, metabolism, Limpinski violation, and the susceptibility. So in our discussion, we factored on these basic things. What do we want our drugs to present with? So the first thing, we wanted a drug which has a better docking score compared to the drug which is Ramelton. Now, if the drug Ramelton had a docking score of 7.8, it shows if you have a molecule with better docking score, let's say 8.1, it means the activity might be better than the parent compound. So that was the basic factor that we checked on when working on this. The next factor was synthesizability. We can get all those drugs with better docking score, but the synthesizability of the drug is not possible. You cannot be able to synthesize the drug. So what we did, we looked at the synthesizability, and for the molecules that I highlighted as the results, the synthesizability was better and not compared to better compared to the parent molecule. Then we had the Limpinski violation. They had no violation formulation, meaning these drugs can be orally given, and then so there was an issue of pig glycoprotein substrate. So it should for low dose, so that we can give a low dose of the drug. We wanted a drug that is not a substrate for pig glycoprotein, so that it can not be effluxed from the target tissue. So we wanted, as much as possible, it should not be a substrate of this molecule of this PAM. And then the metabolism, the molecules showed, some of the molecules showed inhibition of the cytochrome P450 enzymes. As we're going to for the next slide, we're going to see those molecules with better pharmacokinetic property compared to the parent compound. The LD50 parameter also was considered during the analysis of the molecules. Then we actually need a higher LD50 so that we can be able to get a less toxic compound. So in conclusion, the 10 molecules had a better docking score than the parent compounds. 3 molecules had a better pharmacokinetic property than the zinc 000, 42, 22, 622, and then zinc 00000, 3981, 996, and then zinc 0000, 38, 25, 7.1. Now, in these molecules, it is using computation analysis, we can easily get better molecules compared to a parent compound. Now, it will be easier to get this molecule than directly discovering them from, let's say, doing like from plant extract, going to the lab, and then all the procedure down. It will be easier. Now, if we go ahead to synthesize this molecule, it will be better because it will reduce the cost of production, and we can also get these drugs to the local population. So in recommendation, ramelchiol analogs, zinc 000, 42, 22, 622, and zinc 00000, 38, 81, 996, and zinc 0000, 38, 25, 7.1 are potential drug for development. They had good pharmacokinetic and toxicity profiles. Thank you. That's the end of my presentation.
So let us appreciate Oronyi in a better way. Thank you so much. As we did in the first session, kindly just note down the questions that you have for our presenters, and we'll be having them respond to them after this phase or session. Equally, those who are on the online platform, kindly you can just type in your questions, and we'll have them presented at the end of of this phase. Now, on to our next presenter, who is Dr. Naasho Nakunga, who is currently a lecturer of medical physiology at the School of Pharmacy, Kabarak University. He holds over 10 years of teaching experience at a tertiary level, that is, and over 15 years in community pharmacy practice. He has a Bachelor's of Pharmacy from the University of Nairobi and MSc in Medical Physiology from Maseno University. He equally holds a postgraduate diploma in marketing from Chartered Institute of Marketing of the UK. His area of research is in HIV and AIDS, and today he presents to us on the effect of diosmin hesperidine combination on HIV protease inhibitor-induced hyperglycemia in rats. Let us put our hands together in welcoming Dr. Akunga.
Thank you very much. So I'm going to present that title of the effect of diosmin-hesperidine combination on HIV protease inhibitor-induced hyperglycemia in Latus novegicus albinus. Those are Wista rats. I did this work alongside my co-authors. That is, you can see them there. So, presentation is basically, the next slide. Presentation is on your, as indicated there, we'll go through those steps. Next slide. So, our background is basically the fact that HIV protease inhibitors are important drugs that are used in the management of HIV infection in what we call high reactive antiretroviral therapy. But they have also been shown to induce chronic hyperglycemia or hyperglycemia, increased blood sugar in some patients. And the danger of increased hyperglycemia is that it can actually lead to overt diabetes mellitus. Now, flavonoids, these are phytochemicals, and I think if you have been very keen over the last presentation that we have had in this conference, most of the presenters have actually been talking about flavonoids, especially the ones who have been doing presentations in relation to computational studies. So flavonoids have been shown to counter hyperglycemia, and therefore they are candidates for consideration in the management of this hyperglycemia that is induced by treatment with HIV protease inhibitors. Next page. So we have the proper statement, which I think I've partly captured in the background there, is that HIV protease inhibitors are key drugs in HAART, and they are used in the management of HIV/AIDS. And they have led to a remarkable decrease in mortality and morbidity amongst HIV/AIDS patients. However, they are known to cause a number of serious side effects, such as lipodystrophy, lipoatrophy, hyperlipidemia, and insulin resistance. This can lead to glucose intolerance, hyperglycemia, and altered plasma lipid profiles. So the study was designed actually to address this problem, to see if this adverse effect can be ameliorated by administration of flavonoids, and we used a combination of diosmin and hesperidine. Next slide. So justification of the study is that this study is meant to explore if administration of flavonoids can counter hyperglycemia caused by the administration of HIV protease inhibitors, and more specifically reduce the risk of these patients from developing diabetes, over diabetes, and the complications that come as a result of chronic hyperglycemia that leads to the development of advanced glycation end products or AGEs. So far, by the time we were doing this study, it had not been done. That is HIV protease-induced glycemia and the diosmin hesperidine combination, the effect in terms of reducing or countering that hyperglycemia, they had not been done. So we had a justification for engaging the study. So our objective, the main one, was to see if this combination of diosmin and hesperidine could actually reduce the hyperglycemia that is induced, induced in rats using by giving the rats were administered with HIV protease inhibitors, more specifically robinafil stroke ritonafil, or we used two combinations also, atazanafil and ritonafil. Normally you can see the ritonafil there is common to both robinafil and atazanafil. Ritonafil is used as a pharmacokinetic booster. So the specific objectives were three for this study: to determine if actually administering the, HIV protease inhibitors can lead to hyperglycemia. That's by determining the blood glucose levels. Number two, to determine if the administration of the flavonoids, diosmin and hesperidine combination on the effect on blood glucose levels in the rats that are on HIV protease inhibitors, more specifically the LBV/LTV or ATV/LTV, that is robinafil, ritonafil, or atazanafil, ritonavir. Now, last objective was to determine the effect of the administration of the diosmin hesperidine combination on the blood HbA1c levels. That is glycated hemoglobin levels in HIV protease inhibitors treated rats. So those were our objectives. Now, to answer or to address our objectives, we chose to go the hypothesis way. We could have used questions, but we went the hypothesis way. So the first hypothesis was actually to say that there was no significant difference in group mean blood glucose levels after treatment with HIV protease inhibitors, the ones that are indicated there. So our null hypothesis there was that the means will be the same among the 6 groups. There will be 6 groups as you will see in the methodology. Then the hypothesis 2, no significant difference in blood glucose level means, group means, that is, after administration of diosmin stroke hesperidine in the rats treated with HIV protease inhibitors. And the last hypothesis was no significant difference in the group mean HbA1c, that is glycated hemoglobin levels in diosmin hesperidine treated rats. Next slide. So the methods, basically this was a randomized controlled experimental study. Okay, we did this study in the zoology labs in the University of Eldoret. That is not there, but probably I should disclose that. The animals, we obtained them from the animal house at the University of Nairobi. And the animals were 72 in number, so we had a herd of 72 rats. And they were divided into 6 groups, and they were randomly assigned into each of the, into the 6 groups. So there was random assignments to avoid bias. And then each group was subjected to a specific treatment. Of course, there is the way we calculate our sample size. We used the Glenn D. Israeli formula. You can follow it there. I'm not going to go into the details because of time. Then, of course, we analyzed the data by using descriptive methods. Tables there were done, and graphs. And then inferential statistics, mainly we employed the one-way ANOVA, was done to compare the statistical, if there was any statistical significance in terms of differences in the group means. Remember, we have 6 groups, so we want to see if the mean blood glucose levels of the 6 groups are the same or different. And to achieve that, of course, we employed least significant differences, F values, B values, effect sizes. Of course, the effect size here that is relevant to ANOVA is something we call eta squared, and of course, confidence intervals where applicable. The treatment summary is shown there. So we have 6 groups, and each group was subjected to that treatment that you can see. There were group 1, we gave them the normal rat food, the rat berets. Group 2 was given robinafil, ritonafil. Group 3, atazanafil, ritonafil. Group 4, then now we added the flavonoids there, diosmin, aspirin, after treatment with. They were co-administered together. So group 5, the same, only that now we have changed from robinafil to atazanafil. And the group 6, we add the rat berets plus the flavonoids. So let's look at the results. The results are divided into 2. We have the blood glucose levels in animals that were treated with atazanafil, ritonafil. The blood glucose levels in animals that were treated with robinafil. Of course, we will also have the blood glucose levels in animals that were not treated, and then we also look at the HbA1c levels. So, blood glucose levels in HIV protease inhibitor treated rats. What we observed is that the HIV protease treated group had higher blood glucose levels with the maximum effect noted on the 3rd week when compared to the control. This one will become more vivid when we look at the graphs. So those are the means that we evaluated. We, of course, measured the blood glucose levels in millimoles for each animal, and then we took an average for the 12 animals for each treatment. And then, of course, the difference between the control and those ones that were on robinafil and ritonafil, was significant. The one was between the difference in the means, group means between the ones on atazanafil and ritonafil, and the control was also significant, using the ANOVA. A one-way ANOVA demonstrated a highly significant difference in the group means of the 6 groups, less than 6 the p-value was less than 0.001, which is almost 0 anyway. And the eta value, I want us to see the eta value there, that is eta squared, is 0.27. That is the measure of the effect size. In other words, the effect size simply tries to explain the contribution of the treatment to that statistical significance that we are seeing there. And we can say that 27% of the treatment of the significance, the difference was contributed by the treatment. Let's proceed. There's a graph there showing you the various treatments and the trends. You can see the maximum effect, as I said, was seen on the 3rd week. But even after the 3rd week, the animals still on the antiretrovirals had a higher level of glucose in blood, high blood glucose levels. Whether that difference was significant, of course, we will see. But you can see the blue line represents the animals that were not subjected to treatment with ARVs. And you can see that their blood glucose levels was almost stable throughout the treatment, the duration of the study. And then let's see what happened when we added the flavonoids to the animals that were on, that's the next slide, the animals that were on robinafil and ritonafil, or ritonafil, atasanafil and ritonafil. So there is a very detailed report there that is week 1, week 2, week 3. We followed the animals. We did a treatment of a period of 42 days. 42 days in the life of a rat, that's quite a long period of time. So week 1, you can see the first one we are looking at robinafil. The first, second, 3rd week, robinafil was the control. You can see throughout the treatment in week 1, the robinafil, ritonafil, and the control, the mean was significant at the end of the first week. Otherwise, the rest, and week 2 there. And of course, week 3, and then from there, week 4, it was also significant. Thereafter, it was also significant. The 4th week was borderline, but, it was more or less significant. And then thereafter, it wasn't. Then you go, we had now the flavonoids, when you added the flavonoids, you can see now the blood glucose levels. The first week, they were not significant, the difference that in terms of the means. 2nd week, no significant. 3rd week, the difference was significant. 4th week, significant. 5th week, it was significant. 6th week was not significant. So we can see that it was only twice. Otherwise, the first week, of course, it was significant, of course, there you can see. So the results there were a bit mixed. That's what we can conclude, even before we go to the discussion. Then when we have the flavonoids treated animals on HIV protease inhibitors, when we compare the two of them, then you can see that actually there were significant differences. First week, 2nd week, the 3rd week, there was no significant difference. 4th week, no significant difference. 5th week, 6th week. So when it comes to robinafil, ritonafil, the results were fairly mixed. You can see that from the graph, next slide. The graph also just shows the same. You can see when the error pairs cross. When the error pairs normally cross and meet, it simply shows you that, well, there could be a difference, but statistically, it's no difference. And you can see that the error pairs of the control and the animals that were on treatment, on the most part, apart from week 1 and week 2 there, the rest of the duration, there was clearly a difference. Next slide. We also look at atasanavir, ritonafil. you have been looking at robinavir, ritonavir. Now we look at atasanavir, ritonavir. Now, if you look at that one, this one was a bit, I could say, a bit captivating because you can see week 1, most of the time, the results were the difference in blood glucose levels. The control and atasanavir treated animals, the results were significant most of the time, week 1, week 3, week 4, week 5, and Then when you compare the animals that were on atasanavir and the control plus diosmin, then you can see that the difference was significant just once at the end of week 1. Then the rest of the duration of that treatment, the differences were not significant. To me, that simply indicated that by adding the flavonoids to the animals that were already on HIV protease inhibitors, actually the difference between the sugar, the blood glucose sugar was, and the control, which we saw in the first phase of the interpretation of those results, there was no difference, statistical difference apart from the first week of treatment. When you proceed to the atasanavir and the atasanavir plus diosmin, you also note that there was no statistical or significant difference in week 1, week 2, but for the rest of the duration, there was a statistical difference. Simply speaking, that means that the addition of the flavonoids actually did indeed produce an effect by ameliorating or reducing the hypoglycemia that was induced by addition of the protease inhibitors. Next slide. The graph simply illustrates that. You can see, the trends there, the animals on the green line there at the top. You can see the animals that were just treated with atasanavir, the blood glucose levels were generally higher. The ones that were treated with atasanavir plus diosmin and hesperidine, you can see the blood glucose levels were lower, and they were actually like more or less similar to those of the control. And that to us was significant. Now let's move to the comparison of the control and the animals that were treated with the flavonoids. There was no significant difference throughout the duration of the treatment. Let's move to the next slide. Now, if you look at the 3 of them, now you look at the animals that were treated with diosmin, the ones that were treated with atasanavir, ritonavir, diosmin, and the ones that were treated with robinavir, ritonavir, diosmin. Out of the 6 weeks of treatment, we had week 1, week 3, week 5, there was a significant difference. The control group and the atasanavir, ritonavir, diosmin, hesperidine group, that the one that was treated, when it was compared to the control, had a significant difference only once at the end of the first week of treatment. The rest of the time, there was no significant difference. That tells us that, the animals that were on atasanavir and ritonavir, when we added the flavonoids, diosmin, and hesperidine, then the hyperglycemia that we confirmed could be induced actually disappeared. So that means that our hypothesis, as we will see later, was disapproved, that there was no statistical difference. On the other hand, robinafil, ritonafil plus diosmin, esberidin, and atasanavir, ritonafil plus diosmin, esberidin did not show any significant differences throughout the study. So those two, basically, there was no significant difference in terms of their mean blood glucose levels. Yeah. An example is week 3. You can see there is no significant difference because the B value there is 0.113, which is not statistically significant. Next slide, that simply shows you that you can see from the error bars that those differences were the animals on robinafil generally had a higher value, but the ones on atasanafil, diosmin at a lower blood glucose levels. Although, as I've indicated, on cross-examination, you find that those ones are not very, very statistically significant. And next slide. Now, let's move to the impact of the administration of the flavonoids on the HbA1c levels in animals that were on HIV protease inhibitors. Now, the light green part of the graph, those are the mean blood glucose levels that were taken, mean blood HbA1c levels that were taken at the beginning of the study, before the animals were subjected to any treatment. Then the dark green bar of that graph is the measurements or the mean HbA1c percentage, that was taken at the end of the study, that at the end of 42 days, 6 weeks. So you can see at the beginning, the control and, at the beginning and the end, the control, there was no significant difference, although there was, the mean of the control at the end of the 42 days was slightly higher. Then, when it comes to the animals that were on robinafil, ritonafil, you can see at the end of the study, the mean HbA1c levels were elevated significantly. The p-value there is 0.02, and you can see when the error bars do not, cross. Then the animals that were on atasanavir, ritonavir, there was the difference was also significant at the end of the treatment compared to the beginning, and also the levels were elevated in terms of the HbA1c percentage. Now, look, when the diosmin and hesperidin were added, now compare that to the animals that were treated with robinafil, ritonafil alone. You can see the animals that were on robinafil and ritonafil plus diosmin, the blood glucose levels at the beginning and the end did not change. And even the p-value there is almost 1, 0.968, no significant change, which actually indicates that the addition of those two flavonoids did indeed counter or reduce or prevent the HbA1c from increasing. On the other hand, when you look at the ATV/RTV, that is atasanavir, ritonafil, when we added the diosmin and hesperidin, you can see there was even a drastic now reduction in the HbA1c compared to the beginning, the beginning, the animals were not on any drug, but at the end of that treatment, even with the presence of the ARVs, that is atasanavir and ritonavir, the deosmin and the aspirin managed. You can see the impact there. There was a reduction in the HbA1c's levels, percentage, and the mean there is 0.01. And then finally, even the animals that were just treated with deosmin and aspirin, there was also a drop in the HbA1c. And that was significant to us. Now, discussion of results, we can see that the mean blood glucose, tended to be higher when the animals were treated with ARVs compared to the control. One of the consequences of the increase in blood glucose sugars in HIV patients, of course, as we have indicated, is that it can lead to over-diabetes. The references are there. ATV, that is atasanavir ritonavir, caused a higher increase in blood glucose compared to robinavir stroke ritonavir. It was also noted that the maximum effect of the HIV PIs on blood glucose happened around the 3rd week after the commencement of treatment. So it takes a bit of time before you can actually see the hyperglycemia. The results of this study were found to be in line with some of the findings that had been conducted by other scientists in terms of elevation of blood glucose by HIV protease inhibitors. Then when we combined the flavonoids and the HIV protease inhibitors, of course, there was an effect there. And the flavonoids have been shown to exert an antidiabetic effect by upregulating, that's receptor upregulation, the peroxisome proliferate activated receptor gamma. That is a very important nuclear transcriptor. It induces transcription that leads to, especially in adipose tissue, that leads to an increase in insulin sensitivity. The flavonoids exert their actions in the liver also, where they reduce gluconeogenesis. These results demonstrate that co-administration of deosmin, aspirin, by and large, with HIV protease inhibitors had a bigger impact in terms of the reduction of the group mean glucose level rise caused by treatment with atasanavir ritonavir compared to the impact on the blood sugar elevation caused by treatment with robinavir and ritonavir. When administered to untreated animals, those not on the HIV PIs, the deosmin aspirin combination did not have a significant impact on blood sugars. These findings are also, they are corroborate or agree with those that were done by Jandrika et al. There. Next slide, I'm about to finish. On HbA1c, the glycated hemoglobin levels, this is one of the H's. This is one of the advanced glycation end products that happens when we have chronically elevated blood glucose levels. And some of these H's, more specifically HbA1c, tends to lead to a number of the complications that we actually observe in people who have diabetes. For example, we have microvascular complications that leads to increased thrombogenicity of blood and poor wound healing in case of injuries like diabetic foot. Increased levels of glucose may result in glucotoxicity to the beta cells of the pancreas. Increased HbA1c levels may increase the level of developing coronary heart disease and stroke. Those are the references there. Okay. And these findings show that treatment with HIV PIs tends to increase the blood glucose levels, and these increased blood glucose levels led to accelerated glycation of hemoglobin, leading to the increased, observed increase in the percentage of HbA1cs. This is because the level of HbA1c are directly proportional to blood glucose levels, and its generation is driven by the law of mass action. I think we understand the law of mass action there. It is, we have a reversal reaction. The direction of the reaction is determined by the concentration of the reactants. HbA1cs are strongly associated with some of the end-stage complications of diabetes mellitus. In conclusion, treatment of the rats with HIV PIs, the two that we used, increased the blood glucose levels in the rats. The blood glucose levels were higher after treatment compared to the baseline levels. The co-administration of deosmin and aspirin combination with HIV protease inhibitors led to a significant decrease in the group mean blood glucose levels in atasanavir, ritonavir treated group, but not in the robinavir, ritonavir treated group. The largest decrease in the HbA1c, that is glycated hemoglobin levels, was noted in animals treated with the deosmin aspirin combination alone, the ones that were not treated with HIV PIs. Next slide. Still on conclusion, the administration of the HIV PIs produced a significant increase in HbA1cs. The co-administration of flavonoids did not show any significant change in blood HbA1c levels in terms of the animals that were treated with robinavir and ritonavir. On the other hand, co-administration with atasanavir, ritonavir combination led to a significant reduction in the HbA1c. But even without, if you go back and look at the results, you see that before the addition of the flavonoids, there was an increase in animals that had been administered with robinavir, ritonavir. But when you introduced the flavonoids, the percentage levels of HbA1cs remained the same. And that was they were stabilized. So the control group had a slight increase in HbA1c levels, whereas the deosmin aspirin treated group exhibited the largest decrease in HbA1c levels. The null hypothesis, therefore, remember we had hypothesis, and all the null hypothesis that the treatment had no effect on blood glucose and HbA1c levels were rejected in view of the results of the study. Recommendations. So from this study, what are the practical implications? We recommend that as much as further studies needs to be done on the impact of the flavonoids on treatment or drug-induced hyperglycemia, that is iatrogenic hyperglycemia, people should be encouraged to take foods that are rich in flavonoids, the fruits and vegetables, because these ones have been shown to stabilize and even reduce blood sugar, and by extension they can also reduce HbA1c, even in patients who have diabetes, and this can actually prevent the accumulation of HbA1c, and that will actually curtail those complications that we saw accompany increased levels of HbA1cs. Thank you.
Thank you, Dr. Kunga, for that very insightful coverage. At this point, because of time, we are going to pick one or two questions based on the presentation that we've had from Dr. Akunga and our initial presenter, Isaac. So I'll pick one question from the congregation.
Okay, I have one question to Mr. Akunga. I want to get the clarification on why the blood glucose levels reduces fast before spiking at week 1 after start of the treatment. Why the blood glucose levels reduce before spiking, yet the rats are on the medication. Thank you.
Also, my question is to Dr. Akunga. Two questions actually. One, this was animal testing, and you had to transport the Worcester, it was the Worcester rats from Nairobi to Kisumu. So could you expound on how, first of all, some of the confounding variables you identified and how you had taken care of these finding variables to minimize stress? Stress is one of the factors that might induce hyperglycemia in the animals being tested. The other question, basically your research was on inclusion of flavonoids or generally plants to reduce the hyperglycemia in rats. So basically, if we look from my perspective, there's the issue of food-drug interactions. During your research, did you note any changes maybe in terms of the pharmacokinetic profile of the protease inhibitors that were given that could maybe affect now or interfere with the efficacy of the drugs? Thank you.
Dr. Akunga, maybe if you can respond to the raised questions.
Okay. On the first question, that is, there was that noted a drop in the blood glucose levels at the end of the first week of treatment. This was also a bit surprising to us. You know, when you go to do a study, you set your experimental conditions and you also have your expectations. But if you look at the results, you actually note that it is the blood glucose levels of the animals that were on the medication that tended to drop. The blood glucose levels of the animals that were the controls, that the animals that had not been subjected to the HIV PIs actually remained the same, stable. So then, thinking about this, we came to the conclusion that the explanation is like when the animals were administered with the drugs may have interfered with their appetite, and the animals had to get used to, you know, the same way when you are being started on a drug, it can affect your appetite, and that may have led to the low blood glucose levels that we noted. But otherwise, these ones, I can also be very honest and tell you that we were also a bit surprised that there was a dip, and then from that dip you can see the results tend to show a sharp rise in the blood glucose levels. So subjecting the animals to the drug may have interfered with their appetites. Yes, although the animals were eating, but that is what was observed. we are still trying to figure out. Now, you talked about confounding factors, that stress, transporting the animals from Nairobi to Kisumu, actually to Eldoret. It was not in Kisumu, it was Eldoret. The animals were transported and they were not immediately subjected to treatment. They were allowed to acclimatize. The animals actually stayed like for 2 weeks before we started the treatments. And then, of course, when it comes to confounding, we tried to eliminate confounding, stress, etc., extracting blood for blood glucose measurements, because the animals were subjected to the same treatment. You know, even the ones that were the controls, their blood sugar levels were also taken. So that tended, and that's where we had the 6 groups. The reason behind having all the 6 groups was to ensure that we tried to minimize confounding, and also that the animals were treated the same way. So if they had stress, all of them had stress. But as you can see, the animals that were the controls, their blood glucose level is very stable. So that actually addresses the question of confounding of the result. Now, talking of food-drug interactions, of course, the foods are also the sources in most part of the flavonoids. But in this study, of course, we used a very purified form of the flavonoids. And we gave a dosage. The flavonoids we actually used, they are actually used in human beings to treat certain conditions. I'm not going to tell you the name of the drug, where we got these flavonoids from. That is your homework. But the thing is, the flavonoids, asparagine, and diosmin are actually used clinically. So if they work in human beings, that's the way we figured it out. If they work in human beings where they are used to treat certain conditions, then the dosage that is used in humans is the one that we actually transferred to the animals, and we gave the same rate. And so the issue of food, drug interactions, we believe could not feature here, because if it featured in the animals, it could also have featured in the humans who are on the flavonoids, the same flavonoids for the management of other conditions. So that is the way we handled the study. Thank you.
Thank you so much. I hope that is well responded to. Now, in the interest of time, at this moment, we are going to break for our health break. We are going to take our health break. We'll break for 20 minutes. So kindly let us be back by around 12:10, so that we can continue with the next session.